Thank you. Glad to be here today. I totally agreed on Dr. Lee's conclusion slide about post-COVID symptoms involves multiple systems, for example, cardiovascular, pulmonary, neurological system. This is actually a challenge for patients on how and where to get help, as they were already discharged from hospital and having post-COVID symptoms. Traditional rehab system, as you can see on the right, is divided into different specialties by body system. MSK, cardiopulmonary, neurological, etc. Now, rehab clinicians have the opportunity to practice a more holistic approach. At the beginning of pandemic, experts had warned about a tsunami on demand of rehabilitation for COVID survivors. And rehab associations around the world have published guidelines and exercise protocol for COVID recovery. However, there are still barriers when patients is back to community. Exercise intolerance is long COVID patients' biggest complaint. Therefore, when it comes to treating long COVID symptoms, it requires therapists to jump out of a traditional specialty framework and rethink how to use current clinical tools to help dealing with the symptoms more holistically. The purpose of this sharing section is to show you what in your clinical toolbox works with latest evidence support and how to apply it safely on treating COVID symptoms. I have learned from a rehab professor from Israel in a WCPT webinar on COVID rehab. He said, know what you do and do what you know. The goal is to get patients back to daily life, back to community, and back to work. NMES is clinically proven and a standard of care on muscle rehab for most of the MSK indications. The NMES guru, Professor Gerd Alon, published a review article in 2021, included 80 research papers, and presented on a recent webinar. He mentioned that NMES could play a key role in COVID rehab for muscle, but also works for vascular and respiratory dysfunction. The full webinar is available in the reference box. It's an open source, highly recommend. The key takeaways from his talk is that NMES is proven effective in weaning off patients from ventilators and should be continued in post-acute and longer-term phase of recovery. Rehab professionals should consider NMES to implement within rehabilitation pathway for COVID-19. Due to limited time today, I will share the 3 NMES protocols from Professor Alon. We have received more than 50 questions during the registration of this webinar, and most of them could be answered while we walk through the slides. In terms of NMES on respiratory indication, a physical therapist, Mr. David Yu, the senior physical therapist from Queen Elizabeth Hospital, Hong Kong, he pointed out in 2010 the importance of early rehab in ICU. Otherwise, complications can delay the weaning due to the respiratory muscle weaknesses. A research in 2017, it demonstrated NMES for critical ill patients. NMES preserved the thickness of abdominal and chest muscles of critically ill patients. So this is an important foundation for further rehab. On the right is the protocol Professor Gerd Alon recommended in his review articles. Here is the protocol. 2 times a day, 30 minutes per section, current intensity sufficient to activate muscle at exhalation. Current frequency at 30 to 50 Hertz. Pulse duration between 300 to 350 microseconds. Target abdominals, internal external obliques, intercostal muscle, and pectorals. I've made a short video showing the electrode placement, mainly targeting the TA. Let's take a look. Ask the patient to exhale when the steam is on. Inhale when steam is off. The program is set with 6 seconds on, followed with a 6-second off. Professor Alon points out the aim of this treatment is to synchronize activation of muscle during exhalation with patient's breathing pattern. Therapists can consider to use it for COVID patients with dyspnea. The application of NMES on vascular application has been overlooked for many years, despite the effect of NMES on muscle action and improving local systemic circulation needs no explanation. Stefano et al. 2016, he showed NMES acutely mobilize endothelial progenitor cells in critically ill patients. Also in the same year, 2016, Tanaka had also shown that NMES has a positive effect on endothelial function, which is highly associated with long COVID symptoms. NMES not only increases muscle strength, but also improves exercise capacity and the quality of life in patients with chronic heart failure. In the same research, Tanaka also shows that the NMES improves vascular endothelial functions to a similar extent as aerobic exercise, which AMI patients may have difficulty to perform. Same as some long COVID patients. Exercise intolerance, as we mentioned at the very beginning. Implication for therapists. NMES can be applied to patients with unstable hemodynamic status and autonomic imbalance because they can receive NMES therapy on bed without postural changes. NMES technology seems monotonous, but is the way the program decided make the difference? Let me show you how does the vascular NMES program work. Here is the NMES vascular protocol from Professor Alon. 4 to 24 hours a day, current intensity is sufficient to activate muscle action. Current frequency between 0.5 to 2 Hz, pulse duration between 50 to 560 microseconds. Target gastrocnemius or other big muscle group which can contribute secondary circulatory effect. Now, let's take a look on the video. This is a special program designed for facilitating venous return. We have two groups of electrode, group 1 on the calf and group 2 on the quads. Now we are going to start the contraction from the calf muscle. Now you can see the calf start to contract. And then we will have a co-contraction of the calf and the quads for another 3 seconds. This is a special program designed for facilitating venous return. We have two groups of electrode, group 1 on the calf and group 2 on the quads. Now we are going to start the contraction from the calf muscle. All right. Now, I do hope that you had a brief practical overview on the NMES applications for COVID patients in terms of vascular and respiratory dysfunction. Before I do a clinical conclusion, since blood clot is an important topic for COVID rehab, my colleague Anita Kwok, a Novus clinical advisor, will brief us on the evidence and protocol of DVT prevention using compression therapy for COVID patients. The background about Anita: she has over 15 years experience in cardiology, surgical instruments, and devices from various companies. She has provided many DVT prophylaxis training across Asia Pacific countries. Welcome, Anita.
Thank you, Stephen. COVID truly elevates all risks mentioned in the virtuous trial to the highest measure. All hospitalized, including medical ward patients, are recommended for VTE prophylaxis. 2020 systematic review and meta-analysis recorded incidence of VTE 28% in ICU, and 10% in non-ICU. Journals of Thrombosis and Thrombolytics 2021 reported, despite all patients receiving low molecular weight heparin, the incidence of DVT was 46%. Patients with COVID may be predisposed to DVT, PE, and microvascular thrombosis due to excess inflammatory response, endothelial dysfunction, statics of blood flow. Common approach VTE prophylaxis in hospitals are compression stockings to address endothelial damages, IPC pump to move the blood to overcome static blood flow. But what you might not realize is that IPC dynamic compression therapy also help to generate coagulation element, nitric oxide, and fibrinogen. Patients after post-discharge is also recommended to prolong primary VTE prophylaxis up to 45 days or till all symptoms subside, supported by 8 guidelines. Likewise, COVID outpatient also has this risk. How about long COVID patients? When symptomatic, this risk exists. Prophylaxis are needed. In case you have long COVID, consult medical professionals to find the right prophylaxis for you. Another commonly heard long COVID syndrome called POTS, postural orthostatic tachycardic syndromes, meaning that when you are standing upright, your heart rate goes up and it stays up. Latest studies and guidelines from healthcare experts and authorities recommend use of compression wear for dysautonomia. Example, POTS. So, what's the mechanism? COVID is closely related to endothelial dysfunction. When you lose the tone on your vessel, they stay vasodilated, and the positive gravity is making it worse by pulling the blood downward. Since those vasodilated vessels won't constrict on their own, compression therapy helps to compress those vessels and guide the blood to move from distal to proximal. The more compression, the more blood returns to heart. Now, the heart has more blood to pump out, so less dizziness. Because long COVID patient endothelial function is compromised, compression wear improves circulation in the body, more blood and oxygen to the lung, to the brain, less fatigue and dizziness. Besides improving circulations, studies also suggest a positive interaction between compression garments and soft tissue. It leads to increased tissue oxygenation and enhanced muscle function. Since many long COVID patients experience exercise intolerance, they may benefit by wearing compression wear, which helps them to prevent post-exercise damage and pain by reducing edema and promote recovery. Now, back to Stephen to provide a clinical conclusion.
Exercise is medicine. This is also true for COVID recovery. However, recent studies point out that the biggest complaint from long COVID patients is exercise intolerance due to fatigue and dyspnea. This may be understood as poor compliance and discourage the patient to continue the treatment. Therefore, clinicians must demonstrate empathy by monitoring, measuring, and evaluation. This requires a different mindset and clinical considerations from clinicians. Italy, which was heavily hit by COVID, they had developed a full-body in-bed gym last year in order to address the long COVID symptoms, to facilitate the patient able to do exercise on bed, at home. And on the right, according to JOSPT, this year, it highlighted the importance of stop, rest, and pace for long COVID patients in order to work within patient's limit. Let me share another experience from Singapore, Tan Tock Seng Hospital. The physio, she mentioned during an interview that COVID patient needs longer than usual time to go back to pre-morbid situation, and we cannot rush for the progress. She also recommends to use vital signs and PER to monitor training intensity. Empathy is especially important in rehabilitation of COVID patients. Peace and love. It is not something new to those audience who had joined our previous webinar series. This is an acronym for soft tissue management. And I personally think the love here is highly relevant for COVID rehab. Load, optimal loading. It was first published by Professor Glasgow in BJSM 2015. He reminded us that loading is not only mechanical, but also neurological and psychological. Together, they can produce optimal functional outcome. Same for COVID rehab. Optimism. Anxiety and depression are top symptoms of long COVID. COVID rehab journey can be unpredictable and episodic. Listening to patients with empathy, building on small improvement, try to create small positive feedback loop is essential to keep patients optimistic that they will get better. Vascularization is a key to push healing from inflammation stage to proliferation stage. Avoid stuck at chronic stage. When we apply rehab modalities, for example, NMES, compression therapy for COVID rehab, we should always consider how to improve vascularization besides standard protocol for MSK. Exercise. Besides MSK exercise, consider breathing exercise and exercise to improve the heart and the lung functions. Exercise must be personalized, paced, and monitored, and most importantly, evaluated by a HCP. Thank you very much for your time today. I do hope that you find the sharing